This is Pituitary Grand Rounds, an interactive educational program developed and produced by Pituitary World News, featuring doctors and patients in conversations about their cases and the fascinating journeys they embark on as they deal with their conditions.
Mr. Jackson, thanks for joining us for the program today.
You're welcome. It's a pleasure to be here with you.
I find your case particularly interesting for a number of reasons, and we'll discuss those later as we go through. As I recall, you presented at about age 63 with symptoms and signs that led to the ultimate diagnosis of your non-functioning pituitary tumor. I wonder if you could tell us what was going on at that time.
About that time, I was going through a lot of fatigue, headaches, and dizziness as well. And I would go to the doctor and my primary care physician and say, I'm sick, I just don't know what's wrong. I don't have any pain that I can tell you about other than I have headaches and dizziness. And I think he was at a loss at that point to determine. He didn't send me for any lab work or anything like that. And it wasn't until a little while later that I was experiencing severe fatigue, is what I would call it, to the point that I would have to stay in bed most of the day. And one evening I passed out and my family called 911, and I went into emergency where a CT scan was done, and the doctor at first thought I had vertigo. And it wasn't until later on the radiologist that was actually in Australia did a closer look and determined that I had an adenoma that was growing on pituitary.
So you were out of the emergency room by that time and received a phone call.
That was the very next day. I was on the Golden Gate Bridge, headed over to Marin to San Anselmo when my primary physician called and said, Ernie, I have bad news for you. He said, we've located what he said was a large adenoma that was growing on your pituitary, and we need to get you into the hospital and get that taken care of immediately.
Now, a couple of questions. Had you ever heard of the pituitary gland before you received that news?
I had heard of it, but it was somewhat non-sequential. I had no idea what it was about or what it did. I didn't realize until then how powerful that little guy could be. Yeah.
What were your thoughts? You're told you have a tumor and need to have an operation. What was going through your mind at the time?
What he first said, he said, it's a brain tumor. I don't think he said, I think he says it was near the pituitary. He just said it was a brain tumor. And I had to talk to myself. I was on my way to a meeting, not to panic or get upset. And I began thinking about what am I going to tell my family at that point. And I went in that same day. He said, you've got to come in, I need to see you right away. And I went in and he said, this is going to have to be removed surgically. And he gave me the name of two surgeons, and I ultimately ended up at UCSF in the brain tumor unit and saw Dr. Kumar.
Now, you had an MRI after the CT.
Yes.
I'd like to take a look at that MRI, so let's do that now. So this is a coronal image through the pituitary gland, and you can see here that there's a mass, and I'm circling that with my arrow now. And this mass does not appear to be invading the cavernous sinuses on either the right or the left that we see here. But this mass is extending upwards and is in touch with the visual pathways known as the optic chiasm and is potentially threatening vision as a result of its size. Now, on this next image, we see the sagittal section, and it shows the tumor very nicely and its extension above the roof of the pituitary into the area of the visual pathways. Again, I don't see any invasion on this film. So Mr. Jackson was found to have a pituitary adenoma after he presented to the emergency room with symptoms that he had previously seen his physician to try to review what might be the underlying cause. His symptoms and signs probably were related to the tumor. However, we would classify this as an incidentally detected pituitary adenoma. It was not suspected by the physicians in advance of that evaluation. However, it probably was the main cause of his symptoms and signs. Patients with pituitary adenomas can present with other symptoms and signs, including mass effects, such as headaches. They can also have visual compromise as a result of the tumor pressing on the undersurface of the visual pathways. Some patients end up having double vision because tumors can extend laterally into the cavernous sinuses, and especially when they hemorrhage, affect the nerves that control eyeball muscle function, and that is what leads to the double vision. Rarely, we have patients who actually present with nosebleeds as a consequence of a tumor growing into the sinus cavity and bleeding, and then the blood can come out through the nose or go down the back of the throat. Patients can also present with one or more partial or complete deficiencies of anterior pituitary hormones. And in that setting, they may have a number of different symptoms related to the loss of the pituitary hormones that control other glands in the body, such as the thyroid or the adrenals in the testicles in men or the ovaries in women, or loss of growth hormone. And while other patients, though not the topic of this conversation today, can have tumors that secrete hormones and lead to clinical syndromes such as acromegaly, Cushing's syndrome, hyperprolactinemia, or hyperthyroidism. So these are the different ways that patients with pituitary tumors come to medical attention. And it's up to the physician and the patient to get together to try to discern what are the underlying causes of the symptoms and what might be the differential diagnosis, and ultimately find the diagnosis of the pituitary tumor. So it's been about 12 years since your presentation, and I have to admit I can't remember everything about every patient. So I had to take a look at your chart in advance of this program, and I noticed that at the time you had also reported on the first visit you had with me that you had nonspecific headaches. So your headaches probably were related to your tumor. You had also had some fatigue and cold intolerance as well, suggesting maybe your thyroid hormone levels might be a little low. I noted on examination that you didn't have any features of acromegaly or Cushing's syndrome, and you looked reasonably well to me and very healthy, and I would have never guessed in a million years that you had a pituitary tumor. That's the crazy thing about these lesions, is that patients can harbor them and they can significantly affect their health, but there aren't always the obvious visual manifestations of the tumor unless you have a problem with hormone overproduction. Do you remember any other symptoms you might have had at that time?
I would say that in reflecting on it now, I'm beginning to realize that there were other things, but I just passed them off. I'm one of these individuals that I don't focus on. If I have pain, I just ignore it. That's not good, because pain is for a reason. And so the headaches, I would take something like Excedrin. The blurriness, I would just attribute it to being tired or something like that. I think my biggest problem was fatigue, because I could not get out of the bed. I had things to do. I would push myself to do it. And in pushing myself to do it, I could feel my heart rate going up, and I would, it was almost like I was doing a very difficult job manually. I would sweat and so forth. And I was, quite frankly, I was relieved when I found out there was a cause for this, because I couldn't identify it. My primary care physician couldn't identify it either.
So one of the things I've learned as a pituitary endocrinologist is that symptoms and signs don't always tell the whole picture. So you know the next step. We send you to the lab and draw a bunch of blood and look at those results.
Yes, I went to the lab and had an awful lot of blood that was drawn, and and then the results came to you.
Yeah. So I took a look at those results, and interestingly, everything was in the normal range. However, we don't know what's normal for you. And a couple of your laboratory studies were actually in the low part of the normal range. And to me, that would suggest that you might have had partial pituitary dysfunction as a result of those, of the tumor and those levels dropping over time. And that might have accounted for some of the symptoms that you had. One of the problems we have in pituitary medicine is we don't know what a patient's normal levels are supposed to be, but the laboratory results themselves are associated with a normal range that's reflective of what's normal for a population. But we recognize that every individual person has their own narrow normal range. But we elected not to treat you with any medications before surgery. Let me go through some of those laboratory studies that we do. Generally, I like to look at pituitary function tests as two groups of studies. One are what we call dynamic tests, and the other are static tests. And they're all designed to look at pituitary functions. In most patients, we start with the static tests, and then we would do the dynamic tests if indicated based on the results of that static test, or if necessary based on what we see by history or physical examination. So I usually start with a growth hormone and an IGF-1 level, and that's testing for acromegaly and also screening for growth hormone deficiency if the IGF-1 is frankly low. Then we check TSH, T4, and T3 to evaluate the adequacy of pituitary thyroid function. That will also be useful if we suspect a patient has a TSH-producing pituitary tumor that overdrives the thyroid gland. Next, we usually get a random morning ACTH and cortisol level to screen for evidence of adrenal insufficiency or cortisol excess that might be seen in a patient with Cushing syndrome. In men, we usually check LH, FSH, and testosterone levels to look for hypogonadism. In women, we check LH, FSH, sometimes estrogen and progesterone levels, especially in younger women, but just the LH and FSH in older women. And of course, we check the prolactin level to evaluate for evidence of prolactin secretion. Women that haven't had menses that are of reproductive age, we might check an HCG level. If we see evidence of possible acromegaly, we might do an oral glucose suppression test. Possible Cushing syndrome, we may be doing some dexamethasone suppression testing or late-night salivary cortisol levels or additional studies as required. If there's a possibility of adrenal insufficiency, we might do something called a low-dose ACTH stimulation test. And there are other tests that can be done as well to evaluate patients with pituitary tumors when you're trying to understand the biochemistry of the condition. So to pull it all together, you had an incidentally detected pituitary adenoma that was probably causing many of your symptoms. Your pituitary hormones, even though they were normal, might not have been normal for you, and that could have accounted for some of the symptomatology that you described earlier. And your tumor, even though it wasn't compromising your vision, was potentially going to affect your vision severely if something wasn't done. And we had recommended surgery years ago. So what I'd like to do is review with the audience the indications for surgery as I see it. The indications for pituitary surgery vary from patient to patient, and we loosely apply these indications so that we can individualize therapy and do what's best for each particular patient. Generally speaking, a tumor that's greater than 10 millimeters in size or 1 centimeter is a tumor that has demonstrated a propensity to grow and should be removed because it's likely to continue to grow over time. By the way, I apply the same size criteria to patients who have Rathke cleft cysts because they've clearly grown and will probably continue to grow. Patients who have mass effects that we'd mentioned before, whether it be headaches, visual compromise, or double vision, or a nosebleed, probably should also undergo surgery. One special type of mass effect is compromise of pituitary function, so that those patients who have hypopituitarism of some form, loss of one or more pituitary hormones with a deficiency of the target gland hormones, should also undergo surgery because sometimes removing the tumor improves pituitary function. Also, those patients that have hormone hypersecreting tumors such as growth hormone leading to acromegaly, ACTH leading to Cushing's, and TSH leading to hyperthyroidism should also undergo surgery as primary therapy. Patients with prolactinomas can elect surgery or medical therapy. We tend to prefer surgery in certain patients, especially young women who hope for pregnancy, because those tumors can grow during pregnancy. And then lastly, and probably more loosely applied, is patient preference. Certainly we see patients with tumors that don't quite meet the size criteria, and maybe pituitary function is normal and they're not making hormones. But that tumor is clinically relevant and should be removed if that is causing anxiety for the patient or somehow affecting that patient's life or livelihood, such that they have clinical effects of it that aren't measured in any of those other indications for surgery.
Let's take a quick break now to remind you that you're watching Pituitary World News production of Pituitary Grand Rounds, and take this opportunity to reintroduce our guest, Ernie Jackson. Mr. Jackson is discussing his case with Dr. Blevins. We also want to thank you for watching and helping increase pituitary disease awareness. You can help by sharing this program with as many people as possible. Thank you. Now let's return to the program.
So, Mr. Jackson, you underwent surgery with Dr. Sandeep Kunwar, my colleague and probably one of the best pituitary surgeons in the world. Tell us about your experience.
What was interesting about my experience is when I first met Dr. Kunwar, he did explain to me, and my wife was present, that my tumor was so large it was encroaching upon the optical nerve. And there was a gentleman next door to me who he had just had to tell that he had lost his vision because his pituitary tumor was a bit larger than mine and had encroached, and he was already not seeing out of one eye. And so for me, there was a sense of urgency, because it's scary when you learn that you could go blind at any time. And so the surgery was initially explained to me that it was going to be about 3 hours. And this was I thought they were going to take the top of my scalp off and cut my brain cap off, but they actually went through my right nostril. And it was supposed to have been a 3-hour surgery that was actually 6 hours because the tumor was so large. I think I was fortunate to be at UCSF in the brain tumor division because of all of the renowned experts that work in that department, including yourself and Dr. Kunwar. There were people in the waiting room when you go to have an appointment with your physician. They were from all over the world, and they were either waiting to see you or waiting to see Dr. Kunwar or one of the other physicians in the department. So my surgery, I think I was in the hospital for a couple of days, and then I went home to recuperate, and then I had some follow-up visits.
Yeah, it was our pleasure to be able to take care of you in the hospital. It is a scary proposition to think that you have to see a neurosurgeon and have an operation on something that's in the middle of your head. The fortunate thing is that the pituitary gland is right behind the sinus cavity behind the nose, so there's a nice natural pathway to get to without disturbing any major structures. However, it's very close to the carotid arteries, and surgeons, if they are wayward in their approach, are going to potentially cause significant harm to patients. And this is why we believe that patients should receive care for pituitary disorders at a pituitary center of excellence, which you certainly did. Now, I saw you I think I saw you in the hospital, and then I saw you about 6 weeks after your surgery, and we reviewed your MRI and saw that Dr. Kunwar had removed every bit of your tumor, so you had what we call a gross total resection. I also looked at your pituitary functions, and all of them were in the normal range at the time. Again, normal doesn't mean they were normal for you, but they were not going to excite me and make me prescribe a bunch of medications at the time. And then we also reviewed your pathology report, and the pathologist had done some special stains on your tumor and said that you had what looked like a non-functioning pituitary tumor. And at the time, we did 3 stains to learn that. We stained for the hormones made by the pituitary. Yours was negative, so it gets classified as a non-functioning tumor at the time. Now, since then, we've learned a lot about these non-functioning tumors. So let's talk about those briefly. Non-functioning pituitary tumors or non-secreting tumors used to be thought of as just a group of tumors that didn't make hormones. But with molecular biology and immunochemistry and other techniques to look at these tumor cells, we've learned that they're actually a very heterogeneous group of tumors. The most common type of non-functioning tumor is actually a tumor derived from the cells that produce LH and FSH, and they're called gonadotroph adenomas. Most of them don't secrete the LH and FSH. However, we do see occasional patients that have hyperfunctioning tumors and secrete LH and FSH that cause either ovarian stimulation or testicular stimulation. There are tumors called null cell adenomas, which basically come from no particular hormone-secreting pituitary tumor. They're just a tumor that is non-functioning and looks like a bland pituitary tumor cell under the microscope. One of the more worrisome types of non-functioning pituitary tumors is that of a corticotroph adenoma. We refer to these as silent corticotroph adenomas. There are several different subtypes, at least two major ones. And they produce but don't release an effective molecule of ACTH, or else produce and don't release it. Interestingly, if you look at all ACTH-producing tumors that come out of patients and go to the pathology laboratory, 45% of them are non-functioning or silent corticotroph adenomas. They're harder to cure, often are invasive, and often are recurrent. So we worry about these and tend to treat patients aggressively if they have these tumors and have any residual left at the time of surgery. And this is a classic example where doing these molecular studies on pathology tissue can help us define our long-term treatment and follow-up plans. There are actually growth hormone tumors that are also silent. I saw one in clinic yesterday. I've probably seen about 6 of those in my career. It's rare to see it, but you can see silent prolactinomas and silent TSH secreting tumors as well. What's probably more common than those last 3 or 4 types of silent tumors are the plurihormonal or the mixed tumors that will stain for more than one hormone or more than one transcription factor, indicating they may come from a more primitive cell type than some of the more advanced cell types that lead to one hormone secretion. One can also see silent prolactinomas. Those are very unusual, but they do occur. More common is the presence of a plurihormonal pituitary tumor that immunostains for more than one hormone. These may be tumors that are more primitive, if you will, and not as well differentiated as the tumors that are more likely to secrete just one hormone. So a non-functioning pituitary tumor doesn't mean the same thing to everyone. I encourage patients to see pituitary endocrinologists because we recognize the different subtypes of these tumors and can orchestrate a long-term follow-up and treatment plan depending on the actual type of non-functioning tumor that one might have. In Mr. Jackson's case, he was studied 12 years ago, and we weren't doing these advanced studies in our pathology laboratory. So I may ask the pathologist to redo some of those special stains if they still have the tissue block, so that I can understand more about the precise type of non-functioning tumor that he used to harbor. So I've been following you for about 12 years now, and we'll talk more about the importance of long-term follow-up later. But over the time, you had several bouts of fatigue, and we evaluated you and noted that you had a successive loss of pituitary hormones. On several occasions when you'd come with fatigue, we would do more investigations and find these hormone deficiencies. And now I believe you're on full hormone replacement. Wonder if you could share with us what drugs you're taking at the present time.
Sure. I would say the number one might be, if you were to rank them, but is I started off with genotropin. I believe I started off at 5.5, and I'm now at 0.7, which is an injection once a day. I'm also taking dexamethasone. I believe that is 1.37. I take that at night, and I'm taking levothyroxine, I believe it's called. And that's a pill that I take in the morning, and then I take a testosterone gel.
So you're on full replacement hormone therapy, and that wasn't necessary at the time right after surgery. I do recall that your MRI showed that you had very little residual pituitary disease. And we often tell patients that they can get by on about 15% of the gland because the extra 85% is just built-in reserve. And I've seen this happen to a lot of patients in my career, is that they will have normal pituitary functions at surgery. Maybe 6 months or a year later, we start to see those hormone levels declining. And I think what happens in this situation is that the pituitary function becomes attenuated, perhaps because the blood vessel supply was interrupted by surgery. Slowly all this scars down and the pituitary cells don't get enough oxygenated blood, so they die off. In some patients it may be because they received radiotherapy for their pituitary tumors, but in patients like yourself, I think it's simply just a loss of pituitary function over time as a consequence of the tumor and as a consequence of the surgery. And it really, I think, speaks to the importance of long-term follow-up with the physicians who diagnose and treat your pituitary adenoma. So let's focus on the growth hormone deficiency. I tell all patients who have a pituitary adenoma, it's 60% likely they have growth hormone deficiency. If you have surgery, that probably goes to 70% or more in that setting. And the more operations or the more recurrences of tumor, it becomes additive and more likely that you're going to end up with growth hormone deficiency, the more challenges to your gland or the more incidents that lead to the challenges to the gland. We also know that the more hormone deficits that one has, the more likely they'll have growth hormone deficiency. So I sort of expected at some point you would probably develop the deficiency in growth hormone. And we had probably talked at the time that the symptoms and signs usually include things like fatigue, decreased energy, poor exercise capacity, which can translate to inability to do yard work, housework, exercise, your own work, whatever, just get tired and fatigued. People tend to become socially isolated, not want to go out because they're too tired, not want to participate in sports or other activities with friends. Many people actually lose muscle mass and muscle strength and gain fat mass as well. Some patients have, for lack of a better term, brain fog, impaired calculation abilities. They can't remember things very well. And then there are silent manifestations of growth hormone deficiency where you can have decreased bone turnover. Ultimately, that can lead to osteoporosis and poor bone fragility and fractures. And then some patients can actually have a set of different things going on in the bloodstream that increase their risk for cardiovascular disease and stroke. As a consequence of all of that, we're big advocates for growth hormone replacement. I wonder if you could tell us what of those symptoms you might have had at the time you were having the fatigue in the postoperative period in that number of years before we actually diagnosed you and treated you.
I think in general you have most of those I could have checked off. I've had, I think it was embarrassing for me because I couldn't do a lot of things. I would be in bed, lying down somewhere, just didn't have the energy, and it was, I couldn't explain why. I just didn't have that oomph. I was fatigued all the time. Which actually, I think, help inspire headaches, if you will. I've had a lot of bone problems, and as you know, I've had a couple of surgeries already. I've had C2, C3, C5, C7 implants done. They're looking at now some more work on the lumbar area. And as you said, I'm finding out new things that I thought were just aging problems, if you will. But of course, now that I know what's going on with the pituitary, at least I have a reference point and I can explain things to family members and friends. If I don't feel like going somewhere, they understand now,
Yeah, a lot of things do make sense. So in recognition of your symptoms, I decided to do some laboratory studies. And one of the things we did was to check your IGF-1. It's part of our routine testing. And your level was 84, which is normal. And some might have said that's okay and normal for your age. But your previous level was 158. So even though it was normal, it was a significant decline from what we considered to be your baseline. And that suggested to me that you did have growth hormone deficiency. So our next step was to do a stimulation test. And there are a number of those that can be done. There's sort of a historical secular trend in the best test and all of that. We know that the insulin-induced hypoglycemia test is probably the gold standard test, but it's complex and risky, so we don't do that. The two main tests that are available now are called the glucagon stimulation test and the macrolin stimulation test. But for you, we did the glucagon stimulation test, which is my favorite. It's the one that we're set to do at UCSF. And your growth hormone stimulated only to 2.2. Now, normal people mostly go to 5 or higher, in my experience, having tested a lot of normal people. The test cutoff to say whether you have growth hormone deficiency or not is 3. So you were under that. So that test confirmed, along with your symptoms and along with the fall in your IGF-1, that you had growth hormone deficiency. So we started you on the growth hormone, which you mentioned before that you were taking. And we did the usual, start you on a lower dose and titrate it upwards to find the right amount for your body. And I looked through your records just to sort of get the average numbers in my mind for this presentation and see that you're averaging an IGF-1 level of about 170, which I think is perfect for your age. Before, again, we started treatment, you were at 84 before our last baseline before, even though you had pituitary disease, but before it dropped was in the 150s. So I think your dose is right on the money right now. I wonder if you could share us what benefits you could ascribe to taking the growth hormone. What did you notice right away and what changed over time?
I did see a spike in energy, and I wasn't preoccupied with fatigue, if you will, or my inability to accomplish certain things. I tend to have, I do a lot of studying, a lot of research and so forth, so I need my wits about me, if you will. And I noticed that I was able to perform pretty good, doing a lot of long hours of reading and research and writing. So that was a big plus for me.
Very good. So I'd like to share with the group listening that Mr. Jackson, age 75 or thereabouts now, is working on a PhD. So you can do the same. You can do anything if you have pituitary disease. You just have to put your mind to it. Wouldn't you say that's true?
I would say that's true. You have to put everything in perspective, and you have to have that commitment. You know, you should not let this disease control you. You should control it. And certainly with the medications that I'm on now, I feel much better.
Do you feel 75 years of age? You don't look it, by the way. You look much younger than that to me.
I don't feel like it either. You know, my aches and pains, I check them off as just aging process, but I feel great, to be honest with you.
I'm 61 and I do the same thing. I have the aches and pains and the knee swelling, and I attribute that to aging, but I feel much younger than that. I think that's the secret to success.
Absolutely.
So a lot of my patients ask me, how long do I have to take the growth hormone? And I tell them I have a woman who's 98 who started growth hormone at 84, and she was miserable before she started treatment, and it really has given her the boost in life, and she's been able to live through her 80s and into her 90s feeling really pretty good and staying very active. So I think that growth hormone is a lifetime medication. How do you feel when you hear that at your age?
When I hear you say that, I have to say that you're absolutely correct, and I applaud the lady who's 98 now. You know, I don't know how much longer I have to live, but if I can feel good all the way to 98 or 100, if I can live that long, I would certainly want to stick with the medications that I'm having now, especially knowing that my pituitary is gone.
Yeah. Growth hormone is misnamed. It's the main hormone. All hormones are necessary for growth during adolescence, but growth hormone is one of the main promoters of growth, and that's what it's been called all along. But we find that it's a major hormone that regulates metabolism, energy, tissue regeneration, maintenance of bone density, and just a whole host of things, including musculoskeletal and cardiovascular function. So it's really important at all ages, even in the very elderly, in my opinion, in my experience. I know a lot of endocrinologists probably wouldn't treat you with growth hormone. Many of them say that it's still research, or that they don't think it's for people who are over about age 65. But clearly, you're one of legions of patients that I've treated who are in their 70s or 80s who have a good quality of life as a result of treatment. So I recommend that you continue it as you have stated that you will.
I certainly appreciate the quality of care and the medicine that you practice and how it's helped me and, as you said, legions of other patients, because it is a very debilitating disease.
So as we alluded to earlier, our journey together has been 12 years so far, and may it continue indefinitely, to the point that we don't even know who each other are. Maybe we'll be over 100 when that happens. The importance of long-term follow-up has really been illustrated by your situation, where again you develop these pituitary hormone deficiencies after the initial surgery. And we see patients who see us after surgery and their tumor's done, their hormone levels are normal. We never see them again. And I wonder how many patients out there have hormone deficiencies that aren't being diagnosed and treated. So I encourage people to do as you've done and have a long-term relationship with your pituitary team, just so that any hormone deficiencies that present later can be diagnosed and treated. Some people with hormone excesses need to be diagnosed and treated as well. And in that setting, seeing them annually can help you get a sooner diagnosis than simply waiting for things to get worse. One of the other reasons that we like to follow people is because there is a risk of tumor recurrence, and you haven't had that, right?
I have not had that, and oncology, as well as yourself, I do an MRI annually, and watch very closely by a team, the team that you are with, and Dr. Clark, Jennifer Clark as well. And I think what is important here is that I used to kind of keep things to myself, but when you have this type of disease, you don't second guess. You say, hey, listen, I'm not feeling well, the fatigue has returned or whatever, because it's the only way that you can start feeling better if you let your doctor know what's bothering you and what the symptoms might be. I think this is how I eventually got onto all the medications that I'm taking now, because I know there would have been a time when I would not have said anything at all, and I would have been suffering needlessly, to be honest with you,
Yeah, I think being a pituitary patient teaches you to be an advocate for yourself and your health care and to speak up. So you brought up something that reminded me that I was not sure I wanted to discuss during this visit, but during this process of follow-up, surveying for pituitary recurrence, and by the way, we always estimate it's a 12 to 25% chance that a tumor can recur over time. Most of those recurrences occur in the first 3 to 5 years, some with as soon as 6 months to a year. But the latest I've ever seen in a patient who had surgery was 30 years later recurring with a pituitary tumor. So patients really do need the lifetime follow-up. But in the process of doing your scans, we found that you have a low-grade brain tumor, a glial tumor, and many people consider those to be low-grade malignancies, and they don't take them out unless they start to grow. But you're undergoing the follow-up with Dr. Clark and others just to make sure that that behaves itself. So that was a really, I think, beneficial thing of having these periodic MRIs, and we see this often in medicine, is that when you do a scan for one reason, you find other stuff. Like they thought you had dizziness for vertigo, and they did a scan, you had a pituitary tumor. We're scanning you for your pituitary tumor. We find you have a brain tumor as well. So it's kind of interesting how medicine works that way.
Mm-hmm. Yeah, I think that we had a very healthy conversation about that second tumor that was located, and it's at stage 2 right now, and we all agreed that we should not even do a biopsy on it yet. So I think the follow-up is, for me, has been just a gift, if I can put it that way. And the other thing is, I'm fortunate that I live in San Francisco, and I can get to the clinic relatively quickly than a lot of people, because a lot of your patients live outside of California, and some live, some came in from other parts of the world to have their pituitary surgeries done and their follow-up. So it is kind of tough for people who don't have that luxury that I have, but I'm consider myself to be blessed.
Yeah, you make a good point, and I think that's where telemedicine has a future, to enable people who are in more remote or rural areas to connect with experts in large centers. Was there anything else you'd like to share with us today?
I think one of the things I would like just to reiterate to other patients who are out there, that they should not discount or blow off anything that they're feeling, because they think just because I had the surgery, I shouldn't feel this way again. You will have some episodes again. You might start feeling fatigue again. You might have some other apprehensions. I think they should raise the red flag and say, Dr. Blevins, I need to come in and see you as soon as possible. This is my problem. This is what I'm dealing with. Because the sooner that is addressed and treated, the better they'll start feeling. And it could even mitigate a more dangerous problem that might be looming somewhere in their body.
Yeah, that's a very strong point and all very well said. Well, Mr. Jackson, I want to thank you for participating in this program today. This is actually our inaugural, if you will, our first episode of Pituitary Grand Rounds, and we're very delighted that you're able to join us and share your story with us today.
Well, thank you for having me. I've enjoyed this as well. Thank you so much.
All right, you're very welcome. Thank you.
Thank you for watching. Pituitary World News is a non-profit organization supported by sponsors and people like you. We want to thank you for your support and encourage you to read and listen to the vast content of articles, podcasts, and videos available at pituitaryworldnews.org. Please share this information as widely as you can. Thank you.